you so much, Dr. Pavlakis.
Thank you so much for this opportunity. I'm delighted to be back at GlomCon and speak about equity and utility. I gave a similar lecture about 2.5 years ago. So for those of you who have seen some of these slides, I apologize, but the laying of the groundwork, I think, is very important. And so some of it will seem familiar, and then there's more updated data. So let me just show you my disclosure slides. Nothing that I do has any relationship to what I'm presenting, except that I am on the board of directors of the Organ Procurement Transplant Network, which goes by OPTN. I know this is possibly an international audience, so Ayman, if I use jargon that maybe is not accessible to everybody, please let me know, and I can slow down and define what I'm talking about.
Will do. Thank you.
So this is a slide that I start this talk on because I feel like we speak about the concepts, the philosophical concepts about equity and utility, but I came at this really wondering, fine, I understand what they mean, but how do they apply to kidney transplant allocation? Just to lay the groundwork, I'm speaking only about deceased donor transplant at this point. And I would like to go through and just kind of bring up examples of policies or approaches that support equity and policies and approaches that support utility so that we are speaking sort of in the same language. So utility, similar to the word usefulness, right? It basically is you support utility when you have policies that prioritize transplants expected to have a longer graft survival. So you're getting more bang for your buck, right? HLA matching, putting a kidney into somebody that you predict that kidney is going to be in there for a lot longer than if you put it into another person. That is supporting utility or usefulness of the donated gift. Now, equity is really best defined about what it's not. So differences amongst populations in access to transplant should not be affected by factors unless they're intentional. So any of you who are also practicing transplant nephrologists in the United States, you probably talk about KDPI to your patients, as I do. And I would say that anytime I've explained KDPI to my patients, I say, and they've understood 0 to 100, and the kidneys that are going to last the longest are in the 0 to 20% category. And I say we preferentially allocate those or give those out to young people, children and young adults. And no matter who they are, my experience has always been the response is, yeah, that makes sense, right? So this is like a consensus-driven, transparent, broadly held consensus societally, not just within medicine, that when there is a scarce resource, we prioritize children. So that is a difference in access to transplant that we agree on. All right, so what are some of the differences in access to transplant that we do not agree on? I think we can all say that race, ethnicity, socioeconomic status, whether or not you speak English, these things should not affect whether or not you have access to a transplant. And any time that they do, that is a disparity in access that should be addressed. Now, it's nice to have these like little figures and these concepts, but actually applying policy to changing and diminishing disparity in access often seems to threaten the utility. So you don't want to harm utility by improving equity or harm equity by improving utility. And sometimes people will make suggestions at OPTN meetings like, hey, transplants would last longer if we just did this. And really, unfortunately, the outcome would be that you wouldn't transplant a whole group of people that we think should have access to transplant. So, the balance between equity and utility doesn't always have to be a zero-sum game. So as you all know, you're all nephrologists or nephrologically aware, there are racial disparities in kidney care, not just transplant access, but all across the board. Black patients in America who are 2 to 4-fold more likely to develop kidney failure than white patients are less likely to receive transplants. Transplants access inequity that I'm talking about can be due to patient social contexts like insurance problems, health literacy, financial or logistic barriers, but they often result, these disparities, from policies and actions involved.